to Debbie now. And Debbie, we've got a guest, Dr. Ros Jones, with us today. Take us through this.
Yes, good afternoon, and thank you very much. Well, there seems to be an onslaught of pharmaceuticals coming down the line at great speed for babies. And we've mentioned them many times before. First one I'm going to highlight for RSV, which is respiratory syncytial virus. This is a product by Pfizer with a bit of an unpronounceable name, Abrisvo. I'm sure Dr. Jones will correct me. And the second one is the second product, just to remind you, is Beyfortus from AstraZeneca, which is a monoclonal antibody. Now, I also want to remind people as well of Dr. Jones's excellent articles on heart. Dr. Jones has written many excellent articles, and as a consultant retired paediatrician, I would really urge you to go and have a look. And there's actually another article. I'll just draw it to your attention so that you can go and look at the articles on heart. And without further ado, I want to introduce and to thank Dr. Ros Jones for joining us. I'm not a paediatric nurse and I don't have paediatric experience, which is why when I've been concerned about these medications, I'm really grateful to Dr. Jones for her input. So without further ado, welcome, Dr. Jones. Please, could you tell us a little bit about RSV in babies and what your concerns are over these new medicines that are coming down the line? Welcome.
Thank you very much, Debbie. Hello. Yes, bronchiolitis is an infection caused by this RSV virus. It's a common virus. It's been around for, we've known about it for decades. It's presumably been around a lot longer. So there's nothing new about RSV. It comes every winter. It has quite a sharp peak over about 6 weeks when cases go up and then they come down again. And for most people, it just gives you a cough or a cold, but it can be a problem for the elderly, as any winter virus can, but also particularly at the beginning of life. So the babies most at risk are if they're under 6 months at the time of this winter season, particularly if they've been preterm and have other problems. So for most full-term healthy babies, this is not a big deal. That's not to say they don't end up in hospital. And there are, every winter children's wards will be full of kids who've come in with this condition. But they'll get better and they'll be fine. And we can talk a little bit about that later on. So in terms, there's been a long push to try and find a vaccine for RSV. There was one back in the 1960s, which was particularly disastrous. And I think it would have been a much worse disaster now because they'd done some animal work. And that had hinted there might be a problem. But they'd gone ahead and done the first clinical trial in only 40 babies. 20 got the vaccine and 20 got a blank placebo. And they seemed to be fine when they were given the injection, and they made antibodies, as you'd expect. And then come the next RSV season, the placebo babies, one of them landed in hospital and there were no deaths. And the vaccinated babies, 18 out of 20 landed up in hospital and 2 of them died. Well, of course, they then didn't go on to do the big study that was planned. But in today's day and age, we rush everything through without really pacing, first let's do a small study, then a slightly bigger one. How long will we follow them up, etc. That was the background. So then there was nothing available for a long time. I think people were really frightened off because of this experience. And the next thing that came along was a so-called monoclonal. So there are 2 different ways you can gain immunity. Active immunity is when you've either had a disease or had a vaccination and your immune system learns to recognize this foreign bacterial or viral protein so that if you meet it again, you have the memory of how to make more antibodies. And then the other system is passive immunity. And of course, that's what babies get from their mums during pregnancy. Any antibodies that the mother has made to different diseases will cross the placenta naturally and also come across in breast milk. But the baby isn't making them for themselves. So those antibodies only last as long as they last in the system. They'll just be in the circulation and they'll wear off after, 3 to 6 months. And so it was using that system that they produced a monoclonal back in the late 1990s called palivizumab. And it's quite effective, but it was specifically trialed for babies at high risk. And I've certainly had experience of using that. We used to set up a little clinic for babies who were extremely preterm, they'd had chronic lung disease, they might be in home oxygen, and for them, getting RSV could be, disastrous. And the only downside of it really was that it didn't last very long, so it needed monthly injections from October through to February. So the one they've brought out now, which you've just referred to, this Navizumab, has the advantage that it's only one injection. It seems to last for 6 months. So they would give it at the beginning of the RSV season. So if you look at the Green Book, which is the sort of vaccination Bible, it's not been updated and it's still got a nice chart there for who should get palivizumab. And it's worth having a look at that, because if they follow that for this new monoclonal, I would have no argument about it. But what they seem to be doing is they've conflated, if you look at the reports on this Navizumab, they've included a load of studies of full-term healthy babies. And the benefit from those for hospitalizations, we're not talking about deaths, because babies don't die of this in the UK, they just don't. But full-term babies, they've reduced the hospitalization rate from 1.6% to 0.6%. So you could say that's a sort of, 70% reduction, or you could say it's a 1% absolute reduction. So it's not, is it really worth giving this to every baby when we don't have any long-term safety data? And what worries me is any vaccine, you can make a good case for that individual vaccine. But what we're doing is constantly adding more and more to the system. And we don't really have any long-term data on the cumulative benefits of lots of vaccines, whether active or passive, as in this case, and how it affects the developing immune system for a healthy child. And that immune system's got to last them for life. So that's my concern. I think they're rushing this because it's convenient. It's very expensive. And if you look at death, somebody's done a freedom of information for the last 10 years to the Office of National Statistics, and the average death rate per year that they've linked to RSV for the whole population was 5.3 deaths per year. That was 3 per year for over 60s and 2.3 per year for under 60s. There have been several years with no deaths. Now, this is very different from third world countries, where like anything like measles, for example, is a killer if you're malnourished. And RSV bronchiolitis will be a killer if you've got no access to hospitals and oxygen, etc. So that's my worry.
Dr. Jones, thank you so much for that. Very briefly, for people watching, because I know that you've got another appointment to go to, could you tell parents and grannies and uncles and aunties and anybody that's looking after babies at the moment, when should they worry? I mean, what can we do here? Should everybody be running out, or what are the symptoms? What should we be worrying about?
Well, I think the obvious symptom is when a baby's too breathless to feed, because most babies, when they get bronchiolitis, they might breathe a little bit faster, but they're pink, they're a good colour, they're still, plenty of eye contact, they're feeding well, they've got wet nappies. And because it's a viral infection, you can, afford to watch them. But some of them that you can see they're working harder and harder, and because of it's hard work to move the air in and out, they can't breathe deeply, therefore they breathe more quickly, and they get to the point where actually they're too breathless to take a feed properly. And those are the babies that definitely need to be in hospital, because they might just need to have a feeding tube and have the breast milk or formula down the tube for a few days until the virus infection clears. And of course, the other big warning sign was if you're worried about their colour, because of course a small number of these babies might end up needing oxygen. But the proportion, you might have one, in the hospital where I worked, we would have 1 or 2 babies each winter who needed to go on a ventilator for a few days. But we'd have plenty who came in and just had to be given a little bit of oxygen or just feeding and then went home. But the vast majority of the babies in the town never came anywhere near hospital, and that should still be the case.
Dr. Jones, thank you so much, because with all the fear being ramped up at the moment and RSV is very much in the news, it's really reassuring to hear from an expert like yourself. And for parents out there, please go and research. Please make your own informed choice over what you give your babies. Dr. Ros Jones.
Thank you, Debbie. Thank you, Dr. Ros Jones. Okay, Alex, sticking with COVID then.